Good afternoon, everyone. Thank you very much. It is a real pleasure to be here with you and to share this table with great professionals. First of all, I would like to explain to you that Dianova is a network of organizations that operate in countries of Europe and America, and in the fields of education, youth, women, and drug. Within the field of drugs, we cover primary prevention and treatment, rehabilitation, and re-entry. First of all, to remember a little bit the original framework, therapeutic communities was born like an alternative to traditional psychiatric hospital and clinics. The identity trademark was a drug-free, we were talking about not even an aspirin. The original tools were self-help and mutual help between the users as a peer-operated community, and no stable reintegration plan. I insist that reintegration was not even the goal, was not even considered in the program. Here we have a picture of Parellada. This is a therapeutic community where I work, is near Barcelona. And we have a holistic, biopsychological, and educational approach. It's the person in the center of everything, just drugs. We try to promote the acquisition of healthy lifestyles, and we work very hard in individualized educational and psychological goals in this program. We adapt to the necessity of the users. The average duration of the program is between 6 and 9 months. We have a multidisciplinary team to work with them, and above all, we have an outpatient post-treatment follow-up. It means that when the users finish the program and he come back to their society, to their houses, we give support to them and we accompany to them little by little in recovering the usual life. In the last 2 decades, we have witnessed an increasing of new different clients and new profiles, new substance of abuse, and new psychopathological profiles. So everything has to, we have to think if we need for a change or adaptation of our traditional disease methodology. Here we have a statistical data from Dianova, Italy, which corresponds with the Spanish data too. In a data sample of 183 users, we found that almost 40% has an Axis 1 disorder diagnosis, and 47.5% has an Axis 2 disorder diagnosis, and the remaining 12.6% has an Axis 1 and Axis 2 diagnosis. That means that it's a very difficult profile to work with in the traditional therapeutic community with the traditional approach that we have. More specific, in the Axis 1 disorder, almost 40% was a mood disorder. In second place, we have anxiety disorder, and third, schizophrenia. In Axis 2 disorder, we have 32.2% borderline personality, second, antisocial personality, and third, avoidant personality. Our new clients, some traits of users with comorbidity. What we find in them, what have we observed in them? Well, we think that they have low awareness of mental disorder, and not just only for mental disorder, but addictive disorder too, which means a high difficulty almost in the first stage of the program. It's difficult to organize the daily activity with them because they have a passive attitude and poor autonomy in daily tasks. So we need extra staff to control them and to give them some extra motivation. We have observed too that they have a high cognitive and social impairment and a heavy history of hospitalization. A low adjustment to changes in daily routines, and side effects of medication that interferes with daily activities and the daily plan of the therapeutic community. category of different clients with different profiles nowadays. So, due to the fact that comorbidity rates are increasing in the last 2 decades, it has been necessary to adapt approaches to new users' profiles. The client with dual pathology requires highest attention and multidisciplinary intervention, mainly psychiatric and psychological. In the literature, we have 2 options to different approach to work with them in the therapeutic community. One of them is the integrative model, and there are some therapeutic communities where both users live in the community, comorbidity and non-comorbidity users. And the other one is the specific comorbidity model that is a therapeutic community adapted just for dual pathology. Both models have pros and cons. I'm going to speak about the challenge identified in the integrative model because it's the model that we have been working with in our therapeutic community. The integrative model requires to adjust programs to work simultaneously with drug users and with these new user profiles. To begin with, the methodology originally designed for drug abuse shows not to be effective in preventing the high withdrawal and relapse in dual pathology users. So, unless duly addressed, there is a clear lack of specific training to work with dual pathology in the multidisciplinary team, which means high difficulties in facing some situation with these users. This is where both users' profiles cohabit. Many conflicts arise from the lack of understanding between the clients. And we face a high risk of staff burnout because of the lack of training that I mentioned before. So, what changes have we introduced in our TC in order to give some solution to these issues? Well, in the first stage of the program, we have increased the frequency of individual tutoring in unofficial places, not just in the psychological interview. For example, at the lunchtime, at the beginning of the day, we try to talk with them and how are they feel. This is very useful for us to have a good follow-up for this client. In the second place, adjustment, we try to adjust the program intensity to patient abilities and capacity. So it's only the users with drug abuse is different to the dual pathology users. They had a very low frustration tolerance, and we need to work very good with them. In the third place, we have to adapt the intensity to the program to these patients. The phase shift depending on the achievement of objectives, not only for the spending the time in therapeutic community, you're going for the phase 1 to 2. You have to achieve some basic goals for your recovery. One very important change that we have done is supervising the activities on the leisure time, because we find that they have a big lack of motivations and they tend to be inactive in the free time. And finally, we implement specific groups to work with them about medication and focus on how important is the adherence to community life and the psychological treatment. So, to sum up, it is important to emphasize the role of decision-making process about the model of community and related methodology that we want to implement, with the aim of providing a comprehensive care to the profile we have to work with nowadays. Thank you very much.